Hi, I'm Joel Mars. I'm an associate professor at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences, and today we're going to talk about secondary stroke prevention. One question as pharmacists that we always get asked is how can patients reduce their risk for stroke and reduce their future risk of stroke once they've had a stroke, so the secondary prevention population. And so a lot of it fits on with traditional cardiovascular risk factors that we think of with other disease states as well. And so we need to have patients control their high blood pressure. And so if they have diagnosed blood pressure, making sure they're checking that blood pressure and that they're taking their medications, and we're assessing that on a regular basis. Secondly, we need to assess their other risk factors such as high cholesterol. Thirdly, assessing other traditional risk factors, so do they smoke? Fourthly, assessing do they have an increased body weight, and so patients that are overweight are at increase of having future cardiovascular events, so they could have a subsequent stroke or TIA, which is a transient ischemic attack. Another risk factor that you should assess for patients is do they have a family history. So some patients have a high risk because they've had previous cardiovascular events in their family, especially if they've had family members at a young age have events. That puts a patient at higher risk for a future event. And then there's other things such as, are they on appropriate therapies? And so is their blood pressure controlled, their cholesterol controlled, are they controlled from a cardiovascular risk standpoint? And that's where we sometimes bring up, are they on antiplatelet therapy or not? So if we talk about antiplatelet therapy, one factor that always comes up is, should a patient be on aspirin or not, and what's the risk versus benefit there? And so one thing, especially from a secondary stroke prevention standpoint, the guidelines, which actually were just updated from the American Heart Association, American Stroke Association earlier this month in May, was the issue of who should be on antiplatelet therapy and not, and should we use multiple agents for antiplatelet therapy, with aspirin being the primary agent that we use in practice. One of the drivers for that is that we have the most evidence for the use of aspirin in practice in reducing events. There was a recent meta-analysis that showed that we reduced events by about 15% in a population that was treated with aspirin versus not, who had a history of stroke. And so we know that it's an effective agent, and in the guidelines it actually recommends it as the first-line agent to reduce risk of future events in patients who've had a previous stroke. So after aspirin therapy, there is a few other antiplatelet agents that can be used to reduce risk. And so we've had a number of them that have been on the market for a while. And so we have agents like ticlopidine, and then we have a combination product with aspirin and dipyridamole, which is called Agrinox. And so those are two agents that have good data in secondary stroke prevention as an alternative to aspirin therapy. And so the guidelines still prefer aspirin up front, but those would be alternatives as well in patients. We do have another agent called clopidogrel, which has a less strong recommendation in the guidelines just because we haven't studied it as much in the post-stroke population. We have good data in other populations, people that have had heart attacks and things like that, but not as much data in the post-stroke population. So if someone is intolerant to aspirin, that's oftentimes when we're looking at some of these other agents, whether we use the combination of aspirin plus dipyridamole or potentially clopidogrel in that patient population to further reduce events if someone can't tolerate aspirin. One question along those lines that does come up is, if someone failed aspirin, what is the role for these other agents? And so there really hasn't been a good study that said these other agents are more effective if you failed aspirin, but sometimes you will see those used in a patient who's been on aspirin, low-dose aspirin, and they've still had a subsequent event. Sometimes we'll switch them to an agent like clopidogrel or the combination of aspirin plus dipyridamole. So sometimes you'll see patients with the question of whether we should have them on two agents to reduce their events further instead of just one. So we prefer aspirin up front for all patients, but sometimes if they've had another event, would it be better to have them on two agents? So should we combine aspirin plus clopidogrel or aspirin plus one of the newer agents? But recently, with the new guideline update that just came out in May of 2014, they actually do give a lower level recommendation, but you can actually use Plavix or clopidogrel plus aspirin for 90 days or 3 months after an event, which has shown lower future events than just aspirin alone. But the caveat to that is that it does need to be initiated during that acute phase. So it needs to be initiated within basically 24 hours of that acute event. And so would be initiated while the person's in the hospital if they presented with a stroke or transient ischemic attack. But after that, there hasn't really been a good role of using dual antiplatelet therapy, so say aspirin plus clopidogrel long term And the concern is there's actually been a few trials that have shown increased bleeding risks. And so that's one thing that you have to balance out, of reducing cardiovascular events in the future, but not causing bleeding events. And so there have been 2 studies that have looked at combination of clopidogrel plus aspirin. One study looked at it versus aspirin alone, the other study looked at it versus clopidogrel alone, and both studies showed no lowering of cardiovascular events, but both showed a slight increase in bleeding events long term. And so overall, you may have a benefit of dual antiplatelet therapy short term post-stroke or transient ischemic attack, but not long term. So in summary, we talked a lot about what the risk factors are for stroke and how to prevent initial strokes plus future strokes, and then talked about what is the role of antiplatelet therapy. And so overall, most patients should be on aspirin therapy unless they're intolerant to it as a secondary prevention means. One key thing to keep in mind is most patients can be on what we call low-dose aspirin. And so in the United States, low-dose aspirin is considered 81 milligrams that can be gotten over the counter at any local grocery store, pharmacy, wherever you may purchase it at. And so that's generally the recommendation for most patients. But low-dose aspirin is considered anything from 81 to 325 milligrams. So even a 325 milligram dose is appropriate in these patients. We just wouldn't want them taking higher doses of aspirin. But if people are intolerant, there still is a role for some of these other newer antiplatelet agents. Other places where you can actually guide patients to more information about this is you can go to the Million Hearts Campaign website, which will be displayed, the specific details will be displayed below, which has a lot of patient education materials about risk factors plus aspirin use. Other things to remind your patients of are you can actually give them tools such as this to actually write down their medications, because oftentimes patients actually don't necessarily write down things that they take over the counter or recognize them as medications that they would take chronically. And so especially when they're writing their medications down, aspirin, even if they buy it at their local pharmacy over the counter, they still should put that in their medication list, because there is implications with drug interactions as well as bleeding risk if they're on other medications that may interact. And so definitely remind your patients to keep that on their medication list. If you would like more information, we are putting a link to the website for the Million Hearts Initiative in the description below.